Welcome to the 2023 WVEMS protocol rollouts. This is Dr. Stanley.
Hi, I'm Dr. LaPera.
And I'm Dr. Iki.
Today we're going to be reviewing the new 2023 updates to the Western Virginia EMS protocols. We're going to start with some BLS updates that apply to everyone in all levels, and then focus on the ALS-specific changes. We're also excited to announce an update to the app itself. You can accept the update directly on your phone, or you can manually update it from Google Play Store or the Apple Store. The new version will include this new 2023 protocol version, and you'll also see some updates to the interface, such as a larger viewing area. It'll also fix the bug where the app always opened to 2021 and is going to clean out several of the much older versions. An archive of the old versions can always be found on the Western Virginia EMS website.
First are the BLS updates, which comprise the majority of the 2023 changes.
We're also going to review all of the specific Virginia OEMS red dot skills in the Western Virginia EMS protocols to maintain compliance with our current regulations.
All right, first let's discuss number 4 airway. BIAD remains the primary airway for resuscitation in this protocol set. BIAD is one of the OEMS red dot skills, so if you have any questions or you're a new provider, contact your training officer. I think it's important to note that our region has been ahead with this for a long time, so this is likely not new information for you. There is some new literature that suggests that balloon-style devices, like the King Airway, may have a lesser performance in resuscitation when compared to the non-balloon alternatives like the iGel, which is currently the item that we're exchanging for. The science isn't conclusive in this area. We will follow it closely, and if you have any questions, contact your operational medical director or send them to the protocol workgroup.
Orogastric tubes also remain at the AEMT level and is an OEMS red dot skill. If you have any questions or if you are a new provider, contact your training officer. OGT can serve as an important adjunct after you establish an airway. It helps to decompress the stomach and improve ventilation. For breathing, CPAP has been updated to include all the forms of non-invasive positive pressure ventilation. Standalone CPAP with PEEP titration remains an important aspect of oxygenation. Likewise, capnography remains an important adjunct to help diagnose and treat respiratory complications. Non-invasive positive pressure ventilation and capnography remain OEMS red dot skills. If you have any questions or if you're a new provider, contact your training officer.
NIPPV also now includes BiPAP. This would only apply if your agency is invested in a standalone BiPAP machine or has a ventilator with a BiPAP mode. It is similar to CPAP, but now you have two pressures to titrate. There's both the inspiratory and the expiratory positive airway pressure. We suggest you start inspiration around 10 and expiration around 5 and titrate from there. If your agency does have these BiPAP devices, you'll receive more training during the agency rollout for that specific device.
And finally, PEDS bag valve mask rate has been adjusted to match with the current PALS guidelines.
Next up is fever. So for the fever protocol, we updated the contraindications for Tylenol and ibuprofen. Active or end-stage liver disease remains a relative contraindication to Tylenol, but minor or remote history of disease is not a contraindication. Likewise, active GI bleeding is a contraindication to ibuprofen, but a previous remote history is not a contraindication to ibuprofen.
Let's talk about Protocol 20, pain. The small text has been updated to point out that you can use weight-based pediatric dosing for small adults under 88 pounds or 40 kilograms.
For nausea and vomiting, the small text now includes a suggestion to sniff an alcohol prep for mild relief of minor nausea. This can give some transient relief until a more definitive solution is implemented.
Protocol 24, medical code. The American Heart Association has softened their stance on IO access in cardiac arrest. The new recommendation is to start with whatever is easiest and fastest considering your resources and skill level. It's still likely that an IO for EMS is going to be superior, but you should consider an IV if you have extra resources or limited access to the drill.
In Protocol 28, chest pain, some of the small text around aspirin has been reworded. Just like in the pain medication protocol, active GI bleeding remains a contraindication to use, but a prior remote history is not a contraindication to aspirin.
Let's talk about Protocol 30, difficulty breathing. Magnesium was removed from the AEMT scope by the Virginia Office of EMS, but it was replaced by a medicine that we think will provide you with some better results. Epinebulized is a new medication at the AEMT level and is also an OEMS Red Dot skill. Epinephrine can be especially useful for adults in extremis from conditions like anaphylaxis. It's also useful in critically ill children with croup or asthma. It is important that you get the correct concentration of epinephrine to mix that. You're going to need the high-dose epi, that is the multi-dose vial and not the cardiac pre-filled. From that vial, draw 5 mLs, which is 5 milligrams, and place that into the nebulizer just like you would any other medication. Turn the oxygen up to 8 and give it to the patient.
For OD and tox, charcoal has been added to the list of antidotes to at least consider. It's not recommended to be a routine intervention, but some toxicologists do still use it. We would expect this only to be used when you have consultation with poison control and they suggest using this medication. Just like several of the other antidotes, it is not included in the drug box.
All right, let's talk about Protocol 42, seizure. A new medicine has been provided regionally for AEMTs. This is Keppra. Keppra is now a second-line medication for prolonged or refractory seizures. If you have concern for status epilepticus or have given several doses of Versed without success, you can start a slow drip of Keppra. Take 2 of the 500 milligram vials and add them to a small bag of saline, either 50 or 100 cc's, and administer that over 10 minutes IV.
As mentioned previously, magnesium was removed from the AEMT scope by OEMS, so it is updated here to reflect intermediate level skill. We also increased the dose to 4 grams to match current best practice.
For stroke, there's a small change in the small text, but we recommend transport with the head of bed elevated at least 30 degrees to help limit aspiration risk in stroke patients. And for pregnancy, TXA has been added for severe postpartum bleeding with poor perfusion after you've done fundal massage. This is our first non-traumatic indication for TXA in these protocols.
We have also changed the small text to reflect best practices around delivery. We encourage skin-to-skin contact immediately following birth by placing the newborn on mom's chest, delay clamping the cord for approximately 60 seconds, then clamp and cut the cord 2 to 4 inches away from the baby to leave an appropriate stump for the emergency department to draw labs and start a line if indicated. Protocol 60, immobilization. We have also updated this protocol to match best practices. Providers now may allow self-extrication of appropriate patients from a vehicle while wearing a C-collar. This would be any patient without significant pain or neurodeficits that can follow directions and wear the C-collar. Patients should be allowed to get up under their own power and lie down on the cot with assistance. The cot should be as close as reasonably possible and should not involve a significant amount of ambulation on the patient's part.
For cold and heat, we had 2 updates. The first involves hypothermic arrest. So we updated the small text to reflect the American Heart Association guidelines. So it's appropriate to follow standard resuscitation, so your standard ACLS with several rounds of medications and defibrillation, even when the patient is hypothermic. For hyperthermia, the small text was updated to help emphasize the difference between hyperthermia, which is heat exposure, and fever, which is a different process. So patients with hyperthermia who are hot and confused should be cooled immediately and aggressively, such as with an ice bath. We also added in Versed at the AEMT level to help control shivering while you're actively cooling the patient.
For Protocol 72, burns, we've made some updates to the small text. We recognize that fluid bolus and other rate-related formulas such as the Parkland formula remain an important component of early burn care, but also wanted to recognize the American Burn Association's recommendation for a rate formula. The protocols support any of these approaches for initial burn resuscitation.
Protocol 74, inhalation. There are no major changes to the protocol, but we did add some small text about riot agents that can be associated with police intervention. Specifically, there is no antidote to tear gas or pepper spray. Remember to protect the crew, remove the patient to fresh air and provide oxygen, and decon with copious amounts of water or saline. Be careful not to contaminate the crew or the ambulance on the way to the hospital. Policy 114, the Regional Drug Box. The Regional Drug Box is losing support from several partner hospitals in the state who do not favor this system. It is likely that the current exchange process is going to be safe for the next 2, 3, or even 5 years, but there are already protocols that include medications that are not in the box. We encourage providers to do the best that they can and understand that the box may not have everything that's mentioned here. We are all familiar with substitutions and amounts of medication that you're not expecting. If you have any concerns, reach out to the hospital with online medical control or discuss these beforehand with your medical director. We would encourage that any agency that is interested in starting their own pharmacy to overcome some of these limitations should contact the WVEMS office for more information.
All right, and now on to some ALS updates. If you're a BLS provider, thanks for your attention. Feel free to skip ahead.
Protocol 8, shock. There aren't any significant changes here, but I think it's important to recognize that during a STEMI, epinephrine may be a suboptimal choice. There is some literature to support that it increases myocardial oxygen demand and perhaps is best avoided. Protocol 46, the psychiatric protocol. There are no changes to Protocol 46. However, OEMS mandates that this is a red dot skill, so we wanted to review patient restraint with medication. Restraint should only be used to increase patient safety and only when the benefits outweigh the risks. If you have any questions or you're a new provider, please contact your training officer or your operational medical director.
For trauma code, we do have an update to pleural decompression with a needle. Current ATLS recommendations suggest using a lateral approach for adults, which is different than what we have used previously. The new location for pleural decompression is the 4th or 5th intercostal space just anterior to the mid-axillary line. Be on the lookout for some additional information and training from the WVEMS office and your agency.
Critical care. Let's talk about a few critical care updates just for your information.
Critical care protocols are for specially trained and credentialed paramedics only. You must be cleared by your agency and maintain all the prerequisites. It's meant for agencies that can commit to increased equipment and drugs. Regional in-service trainings are ongoing. If your agency is interested, they should reach out to the Western Virginia EMS office for more information. There's several other critical care updates that are going to be covered in the in-service, including things related to intubation RSI, vents, push-dose pressors, magnesium, and sepsis. All of these are red dot skills.
Final steps. So that's it.
We appreciate your patience and attention during this video. Your next few steps are to get the attestation form that's linked below or provided to you, complete it, turn it into your training officer, and then wait for approval. It is important to understand that simply turning in the form is not sufficient. You must be cleared specifically by your agency and individual OMD to start using the 2023 version.
And that's it.
If you're interested in participating in the protocol process or have any other questions, please contact the Western Virginia Office of EMS for more information. See you all next year.